Thank you very much, Ruth. Very kind introduction, and thank you indeed for the invitation to participate in this colloquium. I say that both from a personal thanks, but also that you've given time for this very important topic, which, as we'll explore, is often ignored. And hopefully this platform will give us another one to talk about this incredibly important population. As Ruth said, I'm Éamonn O'Moore, or Éamonn O'Moore as Gaeilge, but either way, you can just call me Éamonn. And I'm very pleased to have had a long career in working with people in prison. And I've learned more about public health practice in that space than probably any other. So I hope today that even if you've never set foot in a prison and never intend to, you will still take away from this principles that you can apply to your work, because this is about delivering public health interventions to vulnerable people in specialized settings and their generalizable learnings across the space. So let's talk some numbers. There are about 11.5 million people in prison today globally. This is a huge population. The vast majority of them are men, but as we'll see in a moment, increasing numbers of women are incarcerated. But not only is this a large population, it's also a concern because in those settings where people are incarcerated, there is significant overcrowding, and we see many institutions at full capacity or well over capacity. And this isn't just a problem that impacts on countries that are developing or low-income countries. For example, in England today, the prison system there is so full that they've had to introduce special measures to impact on the way that courts work and the way that people going before the courts are managed, because there is no space in prison systems. So this is a very important problem, and it's a very challenging issue. I mentioned that women and girls are increasingly being incarcerated. Although women form usually the smaller fraction of prison populations in most jurisdictions, nonetheless, in terms of the growth of incarceration of people, women and girls have by far and away been the largest fraction in terms of growth in recent years. And this is really concerning. It represents some real social challenges. And as we'll talk about in a minute, some of the reasons people are incarcerated are more to do with their social circumstances and powerlessness than criminality. Children and young people are also incarcerated in our prison systems. About 23 million children globally are affected by imprisonment, either directly through incarceration or indirectly through parental incarceration. And parental incarceration is actually one of those issues we describe as adverse childhood experiences. And these are known to have significant impacts on the life course of children. And having a parent incarcerated increases the risk as a child that you will be taken into care, that you will have significant disruption to your accommodation, to your education, and indeed to your life chances. So when we think about those people in prison, we need to remember that it's not only the people behind the prison wall that are impacted, but their families and their social networks and their wider community. So this is something that I think we need to keep in mind around health inequalities, and we'll think about that. Also, and this came as a shock to me because, you know, nobody likes to think about this, but if I was sent to prison today, I would be an older prisoner. And I was very upset when I realized that the Ministry of Justice would classify me as such if I was incarcerated. But I would be, if I was sent to prison, among the largest growing fraction of the prison population. So we have got an increasing amount of people who are older prisoners in the prison system. And indeed, in the UK, around 10% of the prison population is aged 50 and over. And there's also an interesting phenomenon known as prison age. So the physiological age of somebody who's had an experience of incarceration is around 10 years older than the chronological age, which represents just multiple stresses in their life and means that people at a chronological age of 50 have some of the same levels of chronic illness and other issues that somebody who's 60 plus years, and that goes on. So it's a challenging population. And just think about, if you've ever been to a prison or even seen one in a movie, think about how people with mobility problems, with sensory problems, who are more fragile and vulnerable, can navigate, can mobilize, can safely be managed in that space. And don't forget, people who are older and in prison also have problems with dementia and with other neurological conditions that make them very vulnerable. So this is a complex space dealing with a complex population and meeting significant challenges that other parts of the health and social care system struggle to meet on a daily basis. The other thing is foreign nationals. So we know that, again, among the fastest growing fraction of any national prison populations are those who were born outside of the state. And there is varying data from across the world. But in terms of Europe, in the UK, around 12% of the prison population are not born in the UK. But other countries have a much higher fraction. So Italy, it's around a third. Austria, it's around 50%. Greece, it's around 60%. Switzerland, around 70%. And Luxembourg, 74%, which just talks to the law-abiding nature of native people from Luxembourg, that they have such a small fraction of indigenous people in their prisons. But it also shows that the challenges of any prison system, small or large, in dealing with diverse cultural needs in prisons is very, very significant. I would have put German data up, but I don't have any, because apparently we don't know how many people are in the German prison system, and we don't know how many were born outside of the state. Just a note. So we have had, as we've said already, evidence of multiple complex needs among people in prison. And those needs have to interface with a challenging environment. So in terms of how we think about people in prison, as we sort of talked in some of the discussion yesterday, we like to have this approach of people, not pathogen, because although we know that many people in prison have higher levels of infectious diseases, particularly blood-borne viruses like hepatitis C, hepatitis B, higher rates of HIV, TB, which is a big problem in some jurisdictions in Europe. A significant proportion of their national TB numbers are driven by the prison population. We also have a huge range of other problems. High prevalence of chronic diseases. When you talk to people about what they think the highest cause of death or the cause of the highest number of mortality in prisons, they tend to think suicide. They tend to think like those would be some of the reasons why people in prison will die. In fact, it's cardiovascular disease and cancer. And again, we need to make sure that the services we provide in prison meet the needs of those chronic diseases. Coupled with that, poor mental health, and we'll talk a little bit more about that. Learning disabilities. People with learning disabilities are hugely overrepresented in the prison population. And imagine the challenge of you living with learning disability, navigating your way through a prison environment, the complex rules, the challenges of a structured regime, the infractions that you might make wittingly or unwittingly, and how people deal with that. Incredibly traumatizing. We also know that many people in prison are using substances, some of them prescribed, some of them not prescribed. Many people starting substance use in their prison journey, not before. So it's a very complex space. And then prior to and post incarceration, vast overrepresentation of people who were homeless prior to incarceration in the prison estate, and people leaving the prison estate being discharged to the streets without secure accommodation. Joblessness is another significant factor, pre and post incarceration, and educational attainment. And as I said, remember, that many of the people who end up in our prison estates have had these adverse childhood experiences, have suffered social deprivation, have been locked out of opportunity, and they're the ones who then end up cycling through the prison estate. So incredibly complex situation. So we've talked about this huge population. We've talked about the huge challenges they face, the complexity of the environment, the complexity of the need, the public health emergency. Why are we not talking about this? What is it about prisons that means people do not talk about them? What is it about prisons that mean that public health institutions very rarely have structured programs to think about this population? And it's a real conundrum because just looking at the stats from an epidemiological perspective, if we had a population this size with this complexity in any other setting or any other place, we would have whole teams set up, whole departments doing research, whole groups of people delivering interventions. So there's something strange going on with this. It's a perception issue. Is it that we have this out of sight, out of mind approach? They're in there. They're not our business. The health system doesn't look after those people. Not our problem. Is it something else? Is it this idea of othering, this idea of a social approbation of people in prison, somehow stigmatizing people, and that we're part of that stigma? Is it simply we're omitting a very valuable opportunity for public health intervention to address health inequalities through structured or systemic lack of joined up thinking, joined up working? So these things need to challenge us. We need to ask ourselves hard questions about why we are so poorly managing the needs of this very needy population. And, you know, even if you don't think prisons are a place you would ever work, or you don't need to think about it, you need to remember that not paying attention to what goes on in these environments poses significant threats to public health that extend well beyond the prison walls. Prisons are a high-risk environment for transmission and amplification of infectious diseases. We know that when infections come into prison, they actually are likely to have a very high attack rate because of overcrowding, because people living at close quarters, because often poor access to diagnostic and therapeutic services, because of other factors due to the prison environment, or disincentives for people to come forward. If you know you're going to be put into isolation and you're in a prison environment, isolation is a punishment in a prison environment. So trying to square that circle of public health interventions to contain and control infectious diseases with the punitive carceral environment, and trying to work out how you do that in a way that is acceptable to the target population is really challenging. And as Ruth said in the intro, I had the privilege and responsibility of leading the COVID-19 response in one of the largest prison estates in Europe when I worked in the UK. And we had to come up with strategies to meet this challenge every day. How do you cope with a highly infectious disease in an environment which has 2 or 3 people living in the same cell, which has people mixing and needing to mix for all sorts of basic services, and which has no control over who comes through its front door? Prisons can't say, "I'm sorry, mate, we're full," because it doesn't work like that. The courts sit, the police do their job, people still get sent through. So it has to cope. It cannot simply shut the door and say there's nobody home. We also in prison have a specific statutory as well as ethical obligation to protect the health of people in prison. People in prison are being punished through the application of law and the courts in a democratic judicial system. But the punishment is deprivation of liberty. It is not excessive exposure to risks of infectious diseases. We are not incarcerating people without regard to their wider health needs. And that is a human right that we need to be very mindful and has legal force, and we need to be very mindful of that. Failure, though, to address these needs puts us all at risk due to the movement of people between prisons and the community. More than 30 million people worldwide move between the communities in prison. So if you have disease amplification in an environment like prison, and then those people move back to their communities, effectively you're transmitting infectious diseases to the community. And as I mentioned earlier, with diseases like TB, particularly in Eastern Europe and the Russian Federation and Central Asian republics, a significant proportion, up to 50% of national TB cases are linked to carceral institutions. And in those settings, because of disease amplification, we're also seeing emergent challenges with drug-resistant TB increasingly. And mindful of those issues, not only around amplification of infectious diseases, but increased risk of antimicrobial resistance, this is a concern that we should all have. Prisons as a population are over-medicated. If you do any sort of survey of drug prescribing in prison, the top three things are always antibiotics, something about analgesics, and then substance misuse or mental health treatments. That's the top three. And that represents something about the culture of prescribing in prison. It also represents how prisons are somehow separate from the normal antimicrobial stewardship that happens in wider health systems. And many people in prison will not complete the course the medication is prescribed, and there's various reasons for that. So essentially, you have got an environment where disease amplification can occur, where there's little access to sophisticated diagnostic and therapeutic services, and where AMR may be now the problem that we don't know we have that will come to bite us. So pay attention. Now, health protection is a complex endeavor, and I spend my life doing it, and every day struggling to get it right because it's hard work, okay? There are many complex components to it, and you will be familiar with all of these. But let's just look at these briefly through a prison lens. So one of the key functions is risk assessment and surveillance of hazards, okay? Prison populations, however, often excluded or not explicitly identified in national surveillance mechanisms. So how can you measure what you cannot see? How can you see what you do not count? If you're not counted, you don't count. Investigation and control of communicable diseases is a key task, but cases and/or outbreaks of infections may not be notified or may not be responded to effectively or in a timely way. And prison authorities may be unfamiliar with how to respond to infections, and public health authorities may be unfamiliar with how to do this within a prison setting. Detection and mitigation of other health hazards is a key part of what we do. Prisons, however, may not be included in alerting or response mechanisms, or mitigations may be unsuitable for prisons. Emergency preparedness, resilience and response, a core part of health protection. Again, prisons may not be routinely included in the EPRR structures. They may not be included in planning exercises, and they may not be explicitly included in response plans. System leadership is a key part of health protection. But again, prisons can be a system blind spot where they are routinely excluded from whole system approaches. And of course, collaboration is a key endeavour in health protection. But as a result of all of the above issues, prisons may be invisible but necessary partners. So we need to understand what is going on behind the walls of these institutions. The WHO has a Health in Prisons programme, and I was fortunate to be director of the UK Collaborating Centre to this programme for many years. It is a unique programme within the WHO in that the Euro region is the only region that has a prisons programme. The programme aims to really increase understanding and awareness of prisons and public health programmes in prison, but explicitly to deal with some of the sustainable development goals, including addressing inequalities and improving health for all. There are several strands or pillars to the WHO strategy that include addressing policy development and legislation to improve prison health, strengthening the interface between prison health systems and wider national health systems, supporting the development of evidence-based practice. And we sort of talked about that a little bit yesterday. It's one thing to say we adhere to evidence-based practice, but if the area you're studying or working in has little evidence because it's not being done, how do you apply evidence-based to something where there is no evidence base? It also aims to foster capacity building processes in prison health in member states, and seeks to build alliances among key stakeholders to coordinate action, create synergies, and mobilize resources to secure sustainability. So in working to support that WHO mission, I am here in the capacity of building alliances, increasing awareness, and advocating. And this is what I hope you will hear today. We came up, when I worked in the UK, with a concept known as the community dividend, and that has now been adopted by the WHO. And that is essentially trying to describe the benefit that accrues to us all from working with people in prison. If we address the needs of this population effectively, it improves the health outcomes for all, the whole community. And even if you just think through the lens of the infectious disease paradigm, it's certainly a very strong argument. It also has wider community impacts. As we said, it has both social and health impacts if we address the needs of prison population. And many offending behaviors are actually driven by unmet health need, whether that links to substance use and/or mental health or some other issues. Addressing health needs can actually reduce reoffending. And if we get this done successfully, we can reduce the cost not only to the health system, but to the criminal justice system and wider society. You know, many governments struggle with raising interest around prison health issues. It's not usually popular with electorates. It's not usually something they're going to win a lot of votes on. But many politicians, and indeed the electorate they serve, are very interested in how we spend our tax money, how we spend our euros or our pounds or our dollars. Making an argument that doing prison health well is actually a cost-effective intervention gets attention, and it also means that we can address things like increasing rates of offending. So it's an argument that we think is important for public health advocates to make. But a key concept is a whole system approach. We cannot do prison health in isolation. If you just start and stop at the prison door, really you're only dealing with a fraction of the problem. So we need a whole system approach. An example of good practice from the UK, and something that I've been proud to be associated with, is the National Partnership Agreement on Prison Health and Social Care. And this is a published strategy document by Departments of Health, Justice, the National Health Service, the prison system, and the National Public Health Agency. It sets out key principles and objectives for the key partners, which is about improving health, reducing reoffending, and supporting access to care through the whole patient journey. And those policies and objectives are published, and we're held to account for delivering them in a very transparent way. The UK has also evolved principles for prison health care, which are based on what we call the 3 Ps. They are patient-centered, they are patient-informed, and they're delivered in partnership. And this is about addressing key issues around equivalence and health equity, delivering evidence-based care, ensuring continuity of care, and making sure that care is delivered by appropriately trained people who are delivering to high standards of care. But a lot of this work is very difficult to do without good data. And again, the NHS in England has led the way in delivering joined up informatics systems that can allow us to really understand both the level of need within the prison health system and how well or not health services delivering in those systems are addressing those needs. And this system has evolved over time to become the Health and Justice Information Service, and this is a key development which other countries could emulate. The system collects data in a whole range of justice settings, pretty much right across the spectrum apart from police custody, and that was a policy decision by the Home Office in the UK, but nonetheless, most of the system is integrated. And that allows all sorts of real patient benefits to be received. So patient care records can be transferred from one institution to another, one part of the justice system to another, and between the prison estate and the community, or vice versa, which allows for continuity of care. And when people are being prepared for release, again, their health needs can be addressed through effective communication. Further, people in prison can register with a healthcare provider. They are de facto NHS patients within the prison estate. They receive an NHS number and they receive access to care. And that care system is then linked in with what's called the NHS spine. So it links with all the other NHS data and digital informatics systems. And then expanding that work to the 5 nations of the UK and Ireland, we did some work pre-pandemic looking at prison health surveillance systems and trying to understand what was going on in the 4 UK nations and the Republic of Ireland. And what we found in that work is that most people agreed that it was a good idea to have good, reliable informatic and patient information data. Why would you not? Most places did some of it. Some did it very well. Some did it not so well. The things that we did well uniformly was usually mostly around infectious disease reporting, because that's usually got statutory requirements. But what was also found from the work was that people had data on prison health needs, but they weren't routinely included, collected, collated, or used to inform regional or national interventions, which felt like a real wasted opportunity. And of course, this is all done in the context of a prison environment. So in thinking about the needs of collecting data in a prison system and thinking about how we do this better, we adapted and adopted the CDC model of public health surveillance to take account of the prison environment. And we talked about the interdependency of health and justice services on well-being. So in other words, if you're living in an overcrowded prison with poor staffing levels and the estate is in disorder, your health and well-being is not going to be well served. So you can't get away from the fact that the environment in which you're living, the prison estate, is a key determinant of health. And so collecting data on those issues within the prison estate is actually an important part of health surveillance. Again, the nature of the population being held in any prison, its demographics. Some prisons specialize in particular groups. So obviously there will be the youth estate, there will be the women's estate, but there are also increasing numbers of prisons that specialize in older prisoners. So again, these will have very different needs to a prison that has mainly young male people within it. Again, the impact of the physical environment on health is well understood. So if you're locked up in your cell 23 hours a day, if you don't have access to exercise, if you only have limited access to family visits, to social and educational activities, this is going to impact negatively in your life. So measuring those activities are really important. And of course, understanding the communities from which people come and return to is essential. But just to say that at the heart of what we do are people. And collaborative working is really the center of everything we do. We also need to remember that prisons are environments where people can be exposed to a whole range of hazards, not just infectious diseases, but the environmental hazards. We had some interesting times in the prison system in England when we had a rise of novel psychoactive substances, and just the fumes, toxic fumes in the air from such products caused health hazards for prisoners and for staff. When we think about health security, we also need to work in an internationalist space. We need to remember that no place is truly an island, and that the impacts of things far distant from our shores can actually wash up in the prison estate. Whether that's thinking about infections like Ebola. We heard about the event in West Africa yesterday. I remember working as a National Incident Director in the UK for that event, and dealing with a possible case in the immigration detention estate. So you can imagine how that was. And also when we met COVID for the first time, we were dealing with potential people traveling, people traveling from China with potential COVID at a time when we were still calling it Wuhan novel coronavirus. So we're on the front line of international health protection. We're not just some backwater. And of course, the key collaborator, the people we need to think about all of the time, are the people we serve. People in prison are people, and we are here to serve the people. It is our ethical, moral, and legal responsibility to meet their needs. So, prisons have to be part of the wider health protection and health security system for their own sake and for everyone's sake. We need to work with a broad range of partners to build the evidence base to ensure that what we do is delivered from a strong understanding of the science, and that the science is strong enough to inform what we need to do. We must co-design a better system to enhance prison health protection and global health security through integration of prisons with emergency preparedness and response, surveillance, infection control, and research activities. We need to remember that prison health is public health. That was the Moscow Declaration of WHO. People in prison need health protection too. And health is a basic human right. And as doctors, as healthcare workers, as citizens, it's our responsibility to ensure that that is delivered. There can be no health without justice, and no justice without health. If you want to know more about it, a little publication that I'm pleased to promote was recently published. And if you're a doctor or a nurse or anyone working clinically in prison, please access this. But thank you for your attention, Gura Milamagov, and thank you.
Yeah, thank you very much, Éamonn. That was a great presentation. Are there any questions from the audience? Here.
Thank you so much for your talk. I'm Martin Viada. I was wondering, you talked about prisons being overcrowded in many countries, but you didn't address that during the presentation, because I was wondering how strong the correlation is between the health conditions in the prison system and the overcrowding of the prison system. Thank you.
Thank you. Yes, I mean, it's a complex question to answer because of all the issues we've talked about, including the lack of good surveillance data, intelligence, and health informatics. What we undoubtedly understand is that overcrowded prisons pose a risk of transmission of infectious diseases. We know that if you have an infectious disease, then an overcrowded prison results in higher attack numbers, and those things are certainly evident. But the reason why our prison is overcrowded is also a reflection of some of the wider challenges within its criminal justice system and its health system. So, for example, there's a world of difference between an overcrowded prison in the Central African Republic versus one in the United Kingdom. Both have the same challenge of too many people confined in the one place, but the way that they're able to manage some of the complications and consequences of that will differ. So this is why it's difficult to say. So can you draw a straight correlation between overcrowding and risk of infectious diseases? The short answer is we don't have the data to enable us to do that with confidence, but it is one of those hypotheses that would need some testing, but I'm sure we would be confident in saying that overcrowding is a key factor in both the risk of and transmission of infectious diseases. And it's why this environmental issue matters. So when we're thinking about metrics for measuring the health of a prison system, then the operating capacity or headcount, or however you like to call it, needs to be a factor there. And that will allow us to build the evidence base to draw those correlations more directly.
Yes, thank you for your talk. It was really great.
Thank
and I was thinking about, that all the prisoners are part of the NHS or are entitled to the normal care. You're probably aware that here in Germany it's different. So people fall out of the normal system, and there are a special parallel system. and there are severe staff shortages because it's not very attractive to work in a prison as a medical doctor. So I just wanted to know, how does it work in practice with the NHS? I mean, are people then carried, or are NHS doctors coming into prison and they have regular clinics there, or is it the other way around? Just a little bit the practical side of it.
So it's a long story, but the headlines are that it began in the mid-1990s with a seminal paper by a former chief inspector of prisons who asked the simple question: were people in prison patients or prisoners? And up to that point, the prison system had managed the health system. So that started a journey in the mid-1990s, which led to a conclusion that people in prison were patients insofar as anyone can be a patient, and it was therefore appropriate that the National Health Service start to provide care for those people. We also around that time looked at the way that care was being delivered in prison, and the short version is that there were very differing standards of care being applied in prisons compared to the community. So different standards in terms of qualifications, in terms of continuing professional development, in terms of application of evidence-based guidance. So people who were receiving care in prison were not receiving care at the same quality standard that there would be in the community. So that led to legislative decisions that the NHS would start to, as they say, commission care in prison. And that led to a program of reform which kicked off in around 2003 and concluded in 2006. So it was a long journey. And then 10 years later, I was involved in some research where we looked at the impact of NHS commissioning on delivering care. And what was undoubtedly the case was that some of those issues about how is care delivered had been improved. So if in the old system, you could be a doctor who worked solely in the prison estate, this was felt to be one of the problems, that people were being isolated from wider professional practice. So now the model is that doctors who work in prisons also work as GPs or hospital specialists in another part of their work. So they usually do either sessions in prison or they have a relationship with the prison to provide services. So we don't have that professional isolation. The particular way in which different services are commissioned or provided will depend on the service, but it's done by, first of all, health needs assessment. So a systematic, rigorous approach to understand in this particular prison for this population, what are the health needs, what services exist, what is the gap, and what do we need to do to address that? And then the NHS commissions services according to that health needs assessment. They have performance metrics around them, so they know how they're delivering that care or not. And so the model is one of an audit cycle of understanding need, delivering services to meet need, reassessing whether the service is delivering the care that we think it needs, and then changing the service model if that is the case. So it was a long process. It was almost a generational process. And so when people ask me, how would you do this in a country, in Ireland where I now work, the Ministry of Justice commissions healthcare in prison. There are pros and cons to every system, but the WHO, in its seminal work, Good Governance for Prison Health in the 21st Century, suggests that the best model is for departments of health rather than ministries of justice to commission health and provide healthcare in prison. But I think even if you don't have an appetite to go down that road, even if your policymakers aren't minded to have the health service commission or provide services in prison, some of the elements of the NHS reform programme could still be relevant. So the model of care, who provides care in prison, how do they do that? The professional standards, the development of performance metrics, the quality assurance, quality improvement programme. These are all things that could be done within whatever system you work. But it is a process, it is a programme. It takes time, it takes commitment, but mostly it takes will. And in the UK, the will was there to transform the system. And it's one of the great public health achievements of the UK health system that it has delivered this, and it remains a model of excellence. The final thought, if you have an explicit statement between the various partners who are involved in delivering care, the departments of justice, the departments of health, the prison system, the public health agency, this really gives you a platform in which to build that co-design and relationship building. So it's why the National Partnership Agreement is a good model. I would advise people to have a look at it, see if elements of it might apply to your jurisdiction and what would that look like. But there are key elements there that I think are a model of good practice for others. So sorry for the long answer, but it was a journey of 25 years in doing it.
Thanks a lot for this great talk. My take-home message from your talk today is that it's really worthwhile having people on board in every working group and guidance writing group with experience in the prison sector. And I was thinking, if we have in our TB guidance documents, if we address this sector well enough, and I think we touch upon always on people being incarcerated, but maybe it would be worthwhile having a special section in each guidance to raise awareness and, well, to give them a voice because they are not able to have a voice on their own. And another thing I was thinking of, because I mean, it's a long time ago when I learned that in some prisons, like in Russia, people tried to get infected, for instance, with MDR-TB. So sputum was kind of
Currency.
sold to get infected because they then had better living condition and especially better nutrition and didn't have to go to working camps and stuff like that. Is that still a thing we have to think of, or is that overcome?
Yeah, I mean, globally, the short answer is yes. Imagine the situation that you were in if you think having an infectious disease that's either difficult to treat or impossible to treat is better for your well-being than not. So these are huge issues, and we certainly do have lots of perverse incentives for people regarding health behaviors, and that works both ways. So, for example, if you are in a cell with another person or two other people, and you develop an infectious disease, the impact on your cellmates is that they may also be isolated as part of infection control. Now, you can imagine that that will not be welcome news for your cellmates. And so there are perverse incentives for people not to present to health services in prison, not to declare, which is why outbreaks are often detected late. Now, we have current challenges in Europe right now with regard to measles. Okay, so most infectious disease we tend to meet. Large numbers of cases in some parts of Europe, large prisons dotted all over Europe, and we have therefore a real risk that we have introduction of infection into these settings, amplification and consequences for the health system and for wider public health. So in a system where there are these sort of perverse incentives for people not to present, or even if they wish to present, they can't access services, or people don't think about measles as a differential diagnosis, just as an example, you will end up with real problems in early detection and prevention and control of an outbreak. So there are lots of things about the prison environment which make the management of infectious diseases, which make the behaviors that we tend to see in wider society different. So we need to think about prison-specific interventions and mindful of the environment as a key determinant of health behaviors, health-seeking behaviors, and the consequences of health issues.
Thank you. Just maybe to add on your first comment, one good example from Germany, although it's all blank. We are currently updating the hepatitis C guidelines, the clinical guidelines, and the group decided that there should be a chapter on hepatitis C elimination in prison settings, and some prison doctors also contribute to this section. So this is maybe a good starting point also for that.
Excellent. And the only thing I will say, though, is mind your language. We do tend to talk about, and it's shorthand English, about prisoners. We prefer to, in formal documents, talk about people in prison or people living in prison, PLP. And the reason for that is, you know, being a prisoner is for most people a temporary state of being. It is not the key defining element of who they are as a person, any more than my being a hotel guest last night determines who I am for the rest of my life. But also it's a dehumanizing thing. You know, we tend to sort of objectify people if we use those words. So we should talk about person-centered language. And I know it's clumsy sometimes to say these things, but for any formal publications, please do that. And one of the achievements that I'm most proud of in my time in the UK is that I managed to convince NICE, which is the National Institute of Clinical Excellence, which is the body that produces evidence-based guidance, to stop talking about people in prison when they were writing TB guidance as hard to reach. As I said, these people are locked up 24 hours a day, 7 days a week. We know where they are. They're not hard to reach. What they are is underserved. We are not doing our job properly to reach out. So language is important because it flips the paradigm, you know, and it makes us think about our responsibilities towards the people we serve rather than almost victim blaming. It's your problem that you didn't want to engage with us because we set up this service, which we thought really worked well. But we didn't ask you your opinion of how it would work and how that would work within your life. So how do we build better services? We co-design with the people we're serving. And prisoners are actually experts by experience. They know more about how prisons work than you or I do, and they know the experience of healthcare in prison and what will work for them and what will make some of those other challenges likely go away.
Thank you. So I'm sorry, in the sake of time, I would ask you to talk to Éamonn during the break, and we will take maybe 1 or 2 questions from the chat.
Okay, yes, we can take 1 comment and 1 question from the chat from our around 130 participants. The first comment was on the share of foreign nationals in prisons in Germany. And one colleague commented that in the federal state of Baden-Württemberg in 2023, there were 48% of foreign nationals. So,
wow.
Yeah.
Well done on getting the data.
Yeah.
The state has a great reporting on.
Fantastic. Well done.
And well, I guess most of the questions have been answered up to now, but maybe one thing, considering that people in prison are categorized as vulnerable population, do you think this classification significantly delays the ethical approval process, thereby hindering the timely conduct of research and investigations to spot the light on their health-related concerns? Do you have any thoughts on that?
So, big question, short answer. There are issues in developing and delivering research in prison settings, and certainly the vulnerability of the population is a consideration. But that comes from a place where the history of research in prison isn't great. There have been examples, unfortunately, of prisoners being used in very unethical ways and in ways that are frankly criminal in the past. So those safeguards are there for a very good reason, and we should certainly observe them. But yes, that does create a barrier. However, if you do nothing else today, please go to WEFREN, the Worldwide Prison Health Research and Engagement Network. Join it. It's free, and there are really useful resources there on how to conduct research in prisons, and everything you want to know about getting ethical approval and conducting and designing prison research is on WEFREN, Worldwide Prison Health Research and Engagement Network. Please join.